Maggie. I hope you can hear me well. So thank you for attending our research talk today. My name is Lathifah Hanum, and you can call me Hanum. Hi, everyone. I'm a lecturer and also a member of the Family Studies Research Group here in Faculty of Psychology, Universitas Indonesia, and I also a PhD candidate from the University of Queensland, Australia, and I will be your moderator for today's session. So today we will discuss the relationship between trauma exposure in childhood and the development of psychotic disorder, and we are very delighted to have Professor Sarah Bendall with us here, our honorable speaker from the University of Melbourne. Prof. Bendall is a clinical psychologist and researchers in youth mental um, and she is currently a professorial fellow at the Center of Youth Mental Health at the University of Melbourne and leads the Trauma and Youth Mental Health Research Unit at Orygen. Her work focuses on the mental health challenges faced by young people, particularly in areas related to trauma, psychosis, and suicide prevention. Prof. Bendall here has recently published studies on topics such as the lived experience of mental disorder in adolescents, the cost effectiveness of online therapies for psychosis, and the role of trauma in youth mental health. And her key areas, if I don't mistaken, are trauma-focused cognitive behavioral therapy, suicide prevention and intervention in young people, psychosis treatment and prevention, and online and social therapies for mental health. So today, Prof. Bendall will present the latest evidence on the relationship between trauma exposure in childhood and the development of psychotic disorder. And we will also explore theorized mechanisms that may lead from trauma exposure to psychosis. And she will also discuss about psychological treatment and a specific treatment model based on this mechanism. But before we start, please allow me to read the rules of our research talk today. So while Professor Bendall present her slides, please mute your speaker so we can follow the presentation well. And for those of you in this room, you can silence your phone while the session is ongoing. And we will have a Q&A session at the end of Prof. Bendall's lecture. And you can raise your hand and shoot your question directly to her. Or you can also use our chat box here, write your question, and I will try to deliver your question to Prof. Bendall. We hope all participants can attend this talk until finished and complete the evaluation survey that the committee will send to you at the end of this talk. And you will get the e-certificate sent by our committee to your registered email. Welcome, please. So without further ado, I will give the time to Professor Sarah Bendall, and the floor is yours.
I'll grab this. Thank you so much for that lovely introduction, and to all of you for inviting me here to talk, to be able to visit you here at UI, and just really delighted to be here. Sorry, right up here. Is that better? Good. So today I'm going to be talking about something that has been something that I've been very passionate about doing research and clinical treatment with for the last 20 years or so, and that is trauma and psychosis. So just a little bit of a quick overview of the talk today. We'll be just having a little bit of a recap on what is trauma, just a little bit of the sort of new evidence around how we conceptualize trauma, and then looking at the prevalence of trauma and childhood adverse experiences in psychosis, talking about the mechanisms, so what may be conferring risk for psychosis in terms of mechanisms of trauma. And then I want to spend most of the talk talking about a model that we have developed at Orygen in Australia, trauma-informed care for psychosis. And that's something that hopefully will be very clinically relevant for those of you who are going to be working clinically in the future. So, first of all, this slide is really presenting what we might consider to be a more traditional way of thinking about trauma. So most of you will be familiar with the things that are on the slide as being traumatic exposures. So you'll see here that we have single incident trauma, or what's sometimes called type 1 trauma, which are sometimes conceptualized as unexpected and out of the blue, like natural disasters, accidents, terrorist attacks, or single incident abuse experiences. We see in public mental health settings, we see a lot of complex or type 2 trauma. So these are traumas where particularly occurring in childhood, and they're prolonged or repeated traumatic events. And they can happen over a very long period of time. And they're often interpersonal. So they're often around, they often involve neglect or physical, sexual, or emotional abuse. Sometimes that can be from caregivers, which makes these kinds of trauma even more distressing and conferring greater risk of mental disorder. And then another trauma that's very important for us as mental health professionals, as psychologists, to be thinking about is secondary trauma. So this is hearing firsthand about the traumatic experiences of other people. So this is when we're doing assessments or undertaking therapy, and we are hearing stories of very difficult things that have happened to the people that we are working with. Hearing these stories and deeply engaging with these stories can be very traumatic for the person who hears them. And this is something that has been really downplayed, I think, in over many years, where we haven't really been facing the effects and the knock-on effects of trauma. So trauma has an effect on the person that it's actually that is immediately experiencing the traumatic event, but it then has knock-on effects to professionals, but also family, friends, the community. So, so it can have a very wide rippling effect. What's very important about that is that we need to notice that in ourselves if we are working with people who are experiencing trauma, and noticing whether we are starting as practitioners, we are starting to experience some of the effects of trauma. So, and sometimes they can be as severe as us getting post-traumatic stress disorder from hearing those stories. And it is certainly not uncommon for professionals who are hearing these stories to develop some of the symptoms of PTSD. And then in an Australian context, we also have to be thinking about intergenerational trauma. So we think about this a lot in Australia, but it's something that communities experience all around the world. And that is where trauma that is experienced in a parent or a grandparent or an ancestor's life then confers risk for those children. The effects of it can be communicated to those children. So that was a more traditional way of thinking about trauma. And now what I want to do is introduce you to quite a contemporary conceptualization of trauma, which we are using more and more in Australia. And actually, it's quite a simple conceptualization. The evidence, more and more evidence, is using large scale studies is clarifying that this conceptualization of trauma is very much fits the evidence. And so this is the 3 E's, and this definition comes from the Substance Abuse and Mental Health Services Administration in the US, SAMHSA. This is a very big organization in the USA that does a lot of research and a lot of develops a lot of guidelines for working in health and mental health. And that one of the great things about SAMHSA is they have a lot of consumer input into their definitions. So they use a very strong evidence base, but they also pass everything through a consumer panel so that when we see these kinds of definitions, we know that they fit with how people with lived experience of trauma experience their own trauma. So, and it's called the 3 E's, which makes it a little bit easier to remember too. It's always good when you've got a definition that's a bit easier to remember. So I'll read it out to you. The individual trauma results from an event, first E, series of events or set of circumstances that is experienced. So then the event happens, the person experiences the event. It happens to their whole body, to their entire being. And that experience is very important. It's experienced by an individual as physically or emotionally harmful or life-threatening. And then it has lasting adverse effects. So that's the 3rd E, on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So it's a bit to get your head around. So I'm just going to show you an example. So this is an example that came from our early psychosis service where I do some clinical work. So this is Michael and Nick, who are children, they're siblings, and their parents angrily argue with each other a lot. So that's the event. Now the experience. Michael finds this annoying and it sometimes makes him sad. So Michael doesn't experience the event as traumatic, but Nick is on the autism spectrum and finds the loud, angry voices of their parents very overwhelming and frightening. And Nick would hide under the table when mum and dad argued, and it was very hard to get Nick out from under the table. And Nick took a very long time to calm down after those experiences. So that's the experience. The effect. Michael talks to a loved one about it, and it only has minor effects on him. Nick copes by pushing their feelings away and shutting down. So Nick isn't able to process those experiences for many reasons. Probably being on the autism spectrum is part of that. And so Nick develops psychosis and comes to our early psychosis services. Now, we can't know that these experiences are the things that are part of the causal pathway that brings Nick to early psychosis services and has Nick diagnosed with a psychotic disorder. But it's definitely a part of Nick's past. And this is the kind of example where we can't ever know exactly what it is that causes in every individual that causes their symptom presentation, but we make a formulation of that. We make our best guess, and we talk to, in this case, we talked to Nick about whether that made sense to them. Okay, so the other thing that's important to be thinking about trauma is that trauma confers risk for more than just post-traumatic stress disorder, PTSD. So we know from an enormous body of literature now that trauma raises the risk of the development of all of the problems on this slide. And there is more and more sophisticated research that's showing us that it is a causal risk factor. It's not the only factor that leads to the development of these disorders, but it's one of the factors. So that's right up there in the big picture of what is trauma. So now we're going to jump down and welcome and start to talk about psychosis. So just a bit of background here again. This paper that's now 10 years old, it's one of the really great papers in this space, showed that 82% of people with a schizophrenia spectrum disorder reported some kind of childhood trauma. So you can see here we have extremely high rates of trauma, and this is not unusual when we look at other data sets. These are the kinds of percentages we see. This is data from our early psychosis service in Melbourne, and we found in this group. So you can see here that well over half of the young people that were coming to our early psychosis services had the events you see on the slide, had experienced those events at moderate to severe levels. So and clearly these are only a few of the kinds of traumas that children can experience. So we expect that there will be much higher rates, but these were the traumas that we assessed for in this study. So traditionally, we've conceptualized childhood trauma to develop for PTSD to develop from childhood trauma, and that psychosis has traditionally been conceptualized as a biological disorder that's, as you see in the slide, completely separate from trauma and the effects of trauma. But the data that we've been working on, the research we've been working on in Australia and other groups have been working on around the world, have now shown us that this is probably not this is not the story. So this was a systematic review and meta-analysis that we undertook, published in 2018. It doesn't feel like that long ago. But this meta-analysis showed that within psychotic disorders, childhood trauma was associated with more severe hallucinations and delusions. So there had always been a school of thought that perhaps there was a subcategory of psychosis that was more trauma related and that was more related to the positive symptoms of psychosis, such as hallucinations and delusions. We still don't absolutely know if that's the case, but this meta-analysis is starting to show us that there may be a pathway from trauma to psychotic disorders, including schizophrenia, that may have a more positive symptom pathway. It's possible that there are multiple pathways. The data is showing us more and more that there are multiple pathways to psychotic disorder and schizophrenia, and multiple outcomes. And we have a lot more work to do to try and unpack all of those things. So, but there are two potential, we've been working in Melbourne on two potential pathways that confer risk for psychosis from childhood trauma. And one of them is post-traumatic intrusions. So we often think of post-traumatic intrusions as flashbacks, as flashbulb moments of the trauma coming back and having a whole of body experience of being back in that trauma exposure. That's traditionally what we think of as a flashback. But actually, post-traumatic intrusions come in. Flashbacks are some of the least common post-traumatic intrusion, and the intrusions we see much more often are having intense memories, unwanted, intense memories of the event. So not a full body, not a full flashback, but having intense memories or having intense emotions when reminded of the event. Just for a little bit of background. So there is a theory that perhaps hallucinations are a variant of post-traumatic intrusions. So you can see that memories, intense memories or intense visual or auditory events are part of flashbacks or intrusions and are also part of hallucinations. When in PTSD, we assume that people will have a memory of their trauma. So when they have a flashback or they have an intense re-experiencing of their trauma, that they will remember that was part of their trauma. But the theory goes that that a hallucination may be a type of post-traumatic intrusion for some people with the memory component gone. And some of the evidence, so this theory was proposed several years ago. There hadn't been very much empirical evidence to support it. So we in Orygen, we looked into trying to see if this might stand up empirically. And Natalie Peach, one of my PhD students, did a fantastic study where she showed that post-traumatic intrusions mediated the relationship between childhood trauma and hallucinations and delusions. It's very good work that she did to show this. And that hallucinations were independently associated with PTSD intrusions in early psychosis. And also importantly, that 9% of the young people in the early psychosis group had hallucinations with the same content as their PTSD intrusions. Now, I'm going to show you an example of that in the next slide, but I just want to give you a warning. This is an example about sexual abuse. So it's a pretty visceral example of what we're talking about here. So I just want to make sure you look after yourselves and that you in the online too, that we're just look after yourselves in terms of reading the content. When I show it to you, it is, I won't read it out, but I'd like you to read it through. I just want to tell you too that one of the reasons that I want to show you this next slide is because one of the things that clinically, one of the things I've seen, I think is happening in working with trauma is that we often find it hard to talk about it with the people that we are working with. And so because it's hard, it's not a nice thing to talk about, it's difficult, and we can sometimes avoid it in the same way that that people with PTSD avoid thinking about their trauma. We also avoid talking about it. And what we need to do is build our confidence and be willing to go there and to talk about the details with our participants. So I'm just going to show you this slide, and you'll see here that the trauma, the post-traumatic intrusion, and the hallucination were the same. Now, just give you a minute here. What's important, one of the things that's important about this is that for this young person in this research study, the young person hadn't, the service that she was attending hadn't assessed her and realized she had PTSD and didn't know the details of her hallucination. They knew about the trauma, they had assessed for trauma, but they didn't know about the content of the hallucination or PTSD. And so I think it's important to realize how we might change our treatment approach if we know this young person has PTSD and we know the content of their hallucination when we know their trauma. So it's a really good example of how we need to know. We need to know the whole picture. We need to have the full assessment in order to make decisions about our treatment plan. So now the other psychological process that might be mediating this relationship is dissociation. So just a little recap on dissociation. So this comes from the DSM-5. Dissociative disorders are characterized by a disruption and or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. And the dissociative disorders are frequently found in the aftermath of trauma. So that's a bit of a mouthful. Just to now jump down into two of the most common symptoms of dissociation. So they are depersonalization and derealization. And what we see in depersonalization is often experiences of unreality and detachment. People often describe feeling like an observer. They describe coming out of their bodies and looking at their bodies from the outside and having perceptual alterations or a distorted sense of time. And then derealization. These are experiences of unreality or detachment with respect to their surroundings. And for people with derealization, individuals, people, or objects are experienced as unreal, dreamlike, foggy, lifeless, or visually distorted. So people often describe that the world is a long way away, or it's through a fog, and they feel disconnected from the world. So we know that dissociation occurs during acute trauma exposure. So and the theory is that happens as a way of psychologically escaping the trauma. If we can't run away or freeze, then we go away in our minds. We leave in our minds, and that actually is a way of coping with trauma. It's using our psychological coping strategies. What then can happen, particularly with children who have ongoing trauma and use dissociation habitually because they have multiple trauma exposures, that becomes a generalized response to stress. And then they can have much less control over dissociating and end up dissociating in situations where it's unhelpful to them. So it then becomes a problem in itself when it started off as a coping strategy. So We've also done research looking at dissociation and psychosis, the symptoms of psychosis. A student of mine, Pamela Sun, undertook a lot of the work we did in early psychosis. And she found that over a third of the young people in our service in the research had dissociative symptoms, and about 14% had a lifetime dissociative disorder. And she also found that childhood trauma mediated the relationship between, dissociation mediated the relationship between childhood trauma and hallucinations and delusions. And we're now actually in our clinic, in our research, we're really trying to unpack this relationship between dissociation and delusions in particular, because there are many overlaps between dissociative experiences and delusional experiences. So what all this really says is that instead of us conceptualizing that childhood trauma is associated with PTSD and all the psychotic symptoms are separate, they really look much more like this. They're all interconnected. Exactly how those interconnections are happening, we don't know yet. That's what we're really trying to unpack in our research lab. And we really need to know that in order to develop more sophisticated treatments for psychosis. So, but now I'm going to jump, given you lots of background now, and now I'm going to jump into treatment for trauma and psychosis. So I'm going to present to you two main approaches. Now, you may be more familiar with the trauma-focused therapies, and I'm only going to be talking about them very briefly because they're quite easy to look up on the internet. You possibly have been trained in them. What I want to talk to you about is a trauma-informed approach for early psychosis. This is something that can be used much more broadly than trauma-focused treatments. We developed this trauma-informed intervention for psychosis, but we have since broadened it out, and we now use this framework for youth mental health, and we are broadening it out into other areas of mental health. So we think it has pretty broad applicability. But first, let me just show you where the research world is up to in terms of trauma-focused treatments for psychosis. Now, this is the first. This was an absolutely groundbreaking research study that was undertaken by David Vandenberg in the Netherlands. So this was the first large randomized controlled trial of a PTSD treatment for people with PTSD and schizophrenia. So before this study was done, there was a kind of an acceptance that we shouldn't be doing PTSD treatments with people with psychosis, because we didn't want to stress them and have their psychotic symptoms exacerbated. So generally, it was believed that we shouldn't, even if someone had PTSD, if we knew someone with schizophrenia had PTSD, that we shouldn't be doing that treatment, because those trauma-focused treatments involve remembering back to the trauma and often talking about the trauma in detail, and that was considered to be too stressful and potentially could trigger psychotic symptoms. What this study showed was that it was safe to do both prolonged exposure and eye movement desensitization and reprocessing. So two trauma-focused treatments with a very good evidence base in PTSD were able to be used really safely in groups with psychosis, with chronic schizophrenia. Very well conducted trial, and the treatment was effective for PTSD. It was a little unclear whether it actually helped with psychotic symptoms. Many of the people in this trial didn't have severe psychotic symptoms. So that was the first study. And then this was another study that was done after the first. Similar study, but instead of using a trauma-focused treatment where people remembered back to the trauma and talked about it, cognitive restructuring was used, but without the exposure component of cognitive restructuring. So the participants didn't need to talk about their trauma in this case. And in this study, there was no difference in PTSD. The effect of the treatment was no different than with a control group. So it suggests that that in psychosis, an exposure component may be necessary. We don't have very many trials yet in this space, but that's starting to be what we're seeing. And then just the last one I want to show you here. This is again a randomized control trial of a PTS treatment for early psychosis. So not schizophrenia, but young people, I think under the age of 30, who were experiencing, some would have had schizophrenia, but having that in the early stages of their psychotic disorder. And as you can see here, for that study, it was effective versus control. It was effective. EMDR was effective for PTSD and psychotic symptoms, and then also remained effective for PTSD symptoms at follow-up. Okay, so that was a very quick, very quick overview of where we're up to with trauma-focused treatments in psychosis. But what I want to spend the rest of the lecture talking about is trauma-informed care approaches, because I think they're extremely important. And I think we need these before we start. We need these in our services before we start undertaking trauma-focused treatments for people with psychosis. So, well, just bring you back again, come back to a bit of background. Trauma-informed care. This trauma-informed care there are many definitions of trauma-informed care. We do not have consensus as to what trauma-informed care is, but one of the most widely used definitions is this one, again, by M.Psi in the US, and this is the 4 R's of trauma-informed care. So a system that is trauma-informed realizes the widespread impact of trauma and understands potential pathways for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved in the system, responds by fully integrating knowledge about trauma into policies, procedures, and practices. And the 4th R, very important, seeks to actively resist re-traumatization. So they are great principles, but how you actually translate them into practice at a clinic level, at a mental health service level, is much less clear. So one of the things we did to try and bring some clarity to the space in youth mental health was to do a systematic review of studies where trauma-informed care had been enacted, had actually been put in place in youth mental health services, outpatient services, and there was data on what that looked like. And so we completed this this review, and what we found was that there were components that needed to be implemented at the system level, and also components that needed to be implemented in clinical practice. And you can see here a lot of the system ones are things that services are often working on, that are often trying to improve. But I think all around the world, we have work that we need to do in these system level changes. But then we also have some very specific clinical interventions, components that we need to do. And these are screening and assessment for trauma, providing psychoeducation for trauma, and providing psychotherapeutic interventions for trauma. So this gave us a little bit more clarity as to what a trauma-informed care system framework should look like in youth mental health services. So this is just really another way of saying that from this is that what we're doing in terms of the system, you can see we have these wider circles that are systems-based levels. And in those levels, what we're striving to do with trauma-informed care is to empower the participants that are coming into our services to take note of cultural, historical, and gender issues, to provide trustworthiness and transparency, to give voice and choice, to have collaboration and mutuality, and to provide safety. And then you can see that right in those central circles, we have the fact that the system should be conducting trauma assessments and providing some kind of trauma treatment. That doesn't necessarily mean trauma-focused treatment for PTSD, but providing some kind of intervention. So what we're going to be talking about today, we could talk about all of these things for days because they're very complex, but because we don't have days, what we're going to be doing is really focusing in on these inner two circles for the rest of the talk: the service conducting trauma assessments and service providing trauma treatments. So, and in the context of early psychosis. And this work started when one of my students, Sarah Gaines, and I conducted a survey of early psychosis clinicians' perspectives on working with trauma way back now, over 10 years ago. I think we did this work actually in 2011. So we surveyed case managers, and what they told us is that they had a lack of training and support to talk about trauma, to address trauma with young people in early psychosis services. So they knew that it was important. They certainly they were very clear that it was something that needed to be addressed, but they didn't know how to do it. They felt very unconfident about whether they could do it safely, and they described potentially opening a can of worms that they wouldn't know how to deal with. So what that told us was that these case managers were not talking about trauma for trauma-informed reasons. They didn't want to re-traumatize the young people who were coming in with early psychosis. They didn't want to exacerbate psychotic symptoms, so they did nothing because they didn't know what to do. So it was a major problem. We needed to help them. We needed to support them, and this told us the kinds of things we needed to do to be able to help them to address trauma. So we developed TRIP trauma-informed psychotherapy for psychosis. So this was a model of trauma-informed care to be delivered within services. And it was a collaboration between researchers and clinicians in our early psychosis service in Melbourne. It was for young people who were aged between 15 and 25 years. And it was there to address PTSD, dissociation, and hallucinations and delusions, if that was appropriate. It was also designed to address safety, and it was conducted within ongoing care coordination by clinical psychologists or social workers or occupational therapists or nurses. So this is the TRIP model. So you can see it has 5 modules, and it is those modules are undertaken within a framework of cultural safety, choice and autonomy, and having a strengths-based approach. And the first module is screening. So this is a brief, supported, non-invasive screening, written screening of the trauma experience and PTSD symptoms. So what we did in the TRIP program was, instead of asking young people about their trauma experiences, asking them verbally, we actually asked them to write in a questionnaire. And I was quite resistant to that idea at first. I thought that we should be sitting and connecting and talking to young people, but we tried it because young people suggested it, and we actually found that it was much easier for young people to write, to tick if things had happened to them. And we set it up very carefully. So we told them that unless we were concerned about their safety, they wouldn't have to talk about any of the things that they ticked on the list in any detail unless they wanted to. So we really tried to keep their autonomy. We supported their autonomy as much as possible and if they didn't want to complete the questionnaire, they didn't have to. But we would revisit it in a few weeks to see if we could then, if they were willing to do it. So we really focused on their autonomy, but also we made it clear that we thought these were really important things to find out about. So just for background, in Australia and New Zealand, where our clinical guidelines tell us that we should be screening for trauma in early psychosis, and the NICE guidelines in the UK also stipulate that screening should be done in early psychosis. So this is something that we know we need to do, but we need to have processes to do it in a way that are supportive and trauma-informed for young people. So this is a brief list of the measures, the kinds of measures that we could use. To be honest, we don't have good screening. We do not have good screening measures for this at the moment. Some of them are quite long. They're not necessarily comprehensive. That is work that still needs to be done. So in developing the TRIP framework, we conducted research on elements of the framework, and one of the screening module was one of the ones we wanted most input from young people about. So one of my students, Tracy Dryden-Mead, who was a senior clinician in an early psychosis service in Adelaide in Australia, she worked with me to implement the TRIP screening module in her early psychosis service, and to do a qualitative research study on young people's experiences of undertaking that, of being given that screening process. So I just want to show you a couple of the quotes that young people reported in this research. So one of them was, They are good questions to be asking. And if they may not be enjoyable to have the answers to all of it, it is very important information that sort of gives you an idea what that person has experienced in the past. And another young person said, so when completing them, they gave me opportunities to like stop or wait between completing them, just in case they triggered anything. They gave us plenty of opportunity to stop doing the questions, like filled out halfway. They asked how I was feeling, whether I needed to take a break, all that kind of stuff. So you're starting to get a sense of how we set up this screening process. So it was a very supported experience for the young people. So that's a very brief description of the screening. And now I want to talk to you about the safety module. So in the safety module, you can see from the diagram that we screen, and if the young people screen, we screen in for trauma, which almost all do based on the data we've seen. We start with the safety module, and we do a lot of that. You'll see the upside down triangle means we're doing a lot of that safety work to start with. So, and what we're doing, that the components in this module are identifying distress using a distress thermometer, which I'll talk you through very quickly soon, teaching distress management, undertaking cultural safety, and safety planning. So safety planning, safety checking is all the things we usually do when we're checking for safety in mental health services. But also, we're really aware that it's possible that the abuse that young people might have described may be still happening. So we need to check on that. Are other people safe from potential abusers? Is there any other current abuse? Because we know that that's common. So I just want to introduce you to the distress thermometer. This is a SUDS rating. For those of you, hopefully many of you will know what a SUDS rating is. So SUDS is the subjective units of distress, and and what that sounds very fancy, but what it means is asking a person, how distressed are you feeling right now in your body from 0 to 10? And it gets used a lot in anxiety treatment to support people to step out of their comfort zone and do things that make them anxious. And what we do is we use a subjective units of distress thermometer or ladder to help them to work out what should be the next step in managing their anxiety. So it often gets used out of the psychology clinic, but what we have used the SUDS thermometer to do in TRIP is to use it in the clinic during the assessment. So what we do is we ask young people, how distressed are you feeling right now from 0 to 10 or 0 to 100, depending on which one you use. And that means they have to look inside and notice what's going on in their bodies, notice their distress. And then they tell us, they give us a number. It's quite easy to just give a number. Some young people with psychosis need a bit of practice at this to be able to notice, but most people can pluck that number out quite easily. So it helps them to notice what's going on in their body at the time. It gives them the ability to communicate with their clinician. So it's an easy way. They don't have to say, stop, I'm feeling terrible right now. There's a number. They can just use a number. And it also tells them that the clinician thinks it's important. So it gives the young person permission to be able to say, and with one number, say, stop, this is a bit too much right now. So we ask the distress thermometer, we actually print out a picture of a thermometer, we laminate it, and we have it on the desk with the assessor or the psychologist. so that it's very clear, and we just keep pointing to it, and we ask the young person, how distressed are you now? And how distressed are you now? We can do that many, many times in one session. If distress gets high, then we enact coping resources that have been, the young person has been trained in, like grounding, relaxation, mindfulness type exercises. What this means is that a young person can be in charge of how much they talk about their trauma. And we'll come to that in a second. So some more qualitative research we did of TRIP. So this young person said she introduced like a thermometer where if it got too high, my emotions, we'd stop and take a break. That was helpful because she knew how I was thinking. So we were communicating, because she had asked every once in a while to make sure I was okay. My case manager also introduced this thing to do when I was having my episodes, listing 2 things I could smell, 2 things I could see, all that kind of stuff. And I do use that when I have episodes, kind of pulls me back to the reality. So you can see here the young person talking about what it was like to be able to do that communication, and also then use those grounding strategies. So, in every culture, we have different ways that we need to approach cultural safety, and so when we're training in this model in Australia, we talk to individual services about how this should be incorporated into the TRIP model. But one of the things that I usually ask of the ways that we do this work in terms of cultural safety is to be thinking about asking services to think about young people within their unique cultural contexts, and have some understanding of the concept of mental health in that context if it's different from the clinician's own. Have some understanding of intergenerational trauma within that context. And then ask this, I think the service, the clinician, the service should be asking themselves, is this service, or are you the best person to be exploring the trauma history of this young person within their unique cultural context? And it may be that it is the right service, but it's something that should be reflected upon. So now we come to the timeline. So the timeline is a slightly different way of doing a PTSD, dissociation, and psychosis assessment. So, and you can see here with the triangles that what we're doing is more safety, and a little bit of timeline. And then as young people are more able to talk about their trauma experiences, we can do more timeline and less safety. So, as I said, the timeline interacts with the safety module. The timeline is a narration. So it's actually, instead of asking we often will ask about current symptoms, and then we go back to the past when we're doing assessments for PTSD, depression, anxiety. In this case, we're actually starting at the beginning and asking young people to describe their trauma experiences, their symptoms, so psychotic, PTSD, dissociative symptoms, other symptoms on a timeline. So it's more of a narrative, and it's more of a story. And that's something that young people have told us is a much more trauma-informed way of asking about these kinds of experiences. We also put strengths and positive experiences on the timeline. So this is an example of they're usually messier and longer than this, but this is an example of a timeline where we had a young person who had dissociation from her early years, from when she was about 6. We have experiences, trauma experiences She witnessed family violence and developed dissociation after that, and then developed hallucinations and delusions of her mum being kidnapped and her mum screaming. And she actually developed those when she had heard about the serious assault of a friend. So she developed them after that traumatic event. And so we were able on the timeline to put together these events and make some sense of how the delusions and hallucinations were connecting back with her trauma. So that's how the timeline can be helpful. So throughout this process of doing work on safety and timeline, we're also providing psychoeducation. And the kinds of things we're teaching young people are what trauma is, what the fight, flight, freeze response is, what are PTSD intrusions and avoidance, and what are dissociative processes. In early psychosis services, they often have a lot of psychoeducation about psychosis, about hallucinations and delusions, but they often don't know anything about these things. We have a lot of resources that we use to support young people in the psychoeducation on the Orygen website. And if you'd like to look at that, you can go to the Orygen website and search trauma, and you can find these resources. Okay, so finally, at the end of all this, we come to a formulation. Now, this can be very simple and often is very simple. So this is a shared understanding of the relationship between trauma, PTSD, hallucinations and delusions, if that's applicable. Sometimes it's not, but sometimes it is, and other symptoms and problems. And it's written if possible. And so what I want to do is just finish by showing you an extract of one of the formulations that when we did a pilot of the trip intervention, the way that we set up the formulation was that the young person wrote their formulation. They wrote a letter to their case manager with their formulation, and the case manager wrote a formulation as well, and then they compared them. And one of the young people in the trip study very generously agreed to let us share some of her formulation letter. So I'm just going to show that to you now. So she said, so this was a 16-year-old young woman. She said, at the start, I was having hallucinations, seeing shadows, hearing voices in my head, and wanted to die. I was fearful all the time and never went out of the house unless I was forced to do so. You've taught me that I had a trunk of memories that I found bad or embarrassing or both, and that the trunk was flowing over so much that it made me remember the bad events that happened in the past. I was very disconnected from life, that all I wanted was to go to my land of better things. This did not help me because the only way forward is to go back to the past and sort the laundry out, so to speak. Even though it was painful, I soldiered on, and with your help sorted most of my laundry, and now I'm ready to live my life. So just finally, I want to thank our research team and our collaborators and students for all the hard work they've done to do this research over the years, and also to thank you for your attention, and very happy for questions.
Okay, it's really inspiring presentation, but first maybe I will ask audience here, do you have any question, or you want to have further discussion with Professor Bendall here before I go to the online participants? Okay, so do you have any question? Not yet. Oh, okay. Still processing. So we have a question here, Prof. From no, Sakar Hanafi is just acknowledge your presentation. Thank you for the warning. This bring a kind remembrance to take ourselves while observing others. But I think we have a question here. Two or three, several questions from Melanie. The first one, could you share about your operational standards regarding intervention for PTSD with EMDR? And has there been any evaluation of how long EMDR has an impact on someone's trauma healing? Is there a certain time limit or can recovery last forever? And the last one is, how do you screen young people, whether in formal schools, in a classical way, or outside the system individually? How do you do it?
Oh, those are big questions.
There's a lot.
There's a lot. So the first thing I should say is I'm not an expert in EMDR. It's not one of the trauma-focused treatments that I've been trained in, and we haven't done any research in EMDR. So I think I know a bit about it. I don't think I know enough about it to share operational standards. I'm sorry, but they are absolutely available. If you look on the internet and find a training in EMDR, then you can definitely find those things out, Melania. In terms of the sort of timelines around EMDR, I'll answer that about trauma-focused PTSD treatments more generally, because in terms of the evidence, EMDR is as effective as other trauma-focused treatments. They don't set, so prolonged exposure, cognitive restructuring, narrative exposure therapy, I think falls into this, EMDR, trauma-focused CBT, they are all very effective for PTSD. They are all equally effective for PTSD. And the clinical trials often use an intervention of somewhere between 12 and 20 sessions for a clinical intervention. It can be undertaken at any time after the trauma. So it can happen within a year, or it can happen 50 years after a trauma has been experienced. Personally, from my clinical experience, I think if exposure therapy happens closer to the time of the trauma, then it can be easier to process those trauma memories and come out of PTSD. That's been my experience. It's very individual. So the way that people move through trauma-focused treatments, the way the recipients of the treatments move through those treatments can be very different depending on the type of trauma, the person, how long it's been, and it's good to have great supervision. If you're undertaking those treatments, it's good to have very good supervision to support you in delivering those treatments.
I guess it answer all of the question. If Ibu Melania have another question, you can unmute yourself and talk directly to Professor Sarah here. Okay. Oh. So here we have our senior lecturer here, Ibu Tri Swardani. We call her Ibu Dani. So she said, thank you for your excellent presentation. I am EMDR trainer and therapist. You have shown the effectiveness of EMDR so well to treat psychosis. She has one question. How collective trauma or historical trauma refers to the cumulative emotional harm experienced by individuals or generations caused by traumatic experiences or even shared by a group of people, such as the genocide of indigenous people, the Nazi Holocaust, violence against Muslim after 9/11, and so on. Is there any research linking it to psychosis?
I don't know of any research. It's a very good question. It's a very good question. I don't know of any research that has looked into the how much psychosis, how the percentage of people that have developed psychosis who have experienced those kinds of collective traumas. I don't know of any such research. I'm just trying to think through. I don't. It would be interesting. It would be hard research to do, but yeah, very hard to do because psychosis is it's not prevalent in the population. It's much harder to do research, population-based research in psychosis because we see it so seldom. So no, I'm sorry, I don't know of any research in that space.
But it's really a good question.
It is. It is.
And Melania, the further question from Ibu Melania is number 3. How about the screening?
Was there another question?
This one, how do they screen young people, whether in formal school?
Yes. Now that is a good question too. So we actually do trauma-informed training in schools, but we don't use the TRIP model in schools. So we use elements of it, but we don't necessarily advocate screening for trauma in a school setting. Because for a lot of reasons, but much because there are so many kids in a school, the resources that would be needed to screen for children at school, and then the ability for school to do anything about that necessarily is very constrained. So we believe that what we should be doing in schools is operating a trauma-informed approach for all children. So we don't need to know. This is one of the things that's really important about trauma-informed care is that in a clinical setting, it's good to screen, but it should be being undertaken in any setting where we are hoping that people will thrive, because there will always be, because we've seen the high rates of trauma in the population, there will be a percentage of people that will have experienced trauma. And so we should be trying to have our services always meet their needs. So we don't necessarily have to know if somebody has been traumatized or not in order to enact trauma-informed care. So in schools, we suggest that we're using all those principles of trauma-informed care, like voice and choice, empowerment, the other ones that are on the slides, which you'll have access to.
We can share this.
Can we go back?
Slide, actually. How I can help. Because one of the audience asked about, can we share the screen again? So, yeah. Oh, stop. Okay. Okay.
So here, what we often are doing when we're doing trauma-informed care in non-clinical settings is we're using the service level. So you can see in a school, we're not necessarily conducting trauma assessments and giving trauma treatment. We'd be hoping that children would be referred to a service that could do that. Possibly in some schools that does happen, but certainly it's usually not what happens in Australia. But what we're wanting is for the school to be using these principles of trauma-informed care: empowerment, cultural, historical, and gender attention to those issues, trustworthiness and transparency, voice and choice, collaboration and mutuality, and safety. And there are ways, there are frameworks for how to do that in schools that are available online.
Oh, okay. Okay. I was just wondering, is it just in Australia, or is globally we use this mechanism to screening the trauma on the children?
So you do that in schools?
No.
You screen for maltreatment in schools?
Not really. I don't think so.
No. Yep.
So it's just in Australia, or?
So in schools we don't screen for child abuse, for trauma. So I'm suggesting in schools you don't do that. You do the things on the outside, the two circles on the outside. We don't in schools conduct trauma assessments or do trauma treatments. We hope that what will happen is those children who are distressed will go to services, will go to mental health services, and they will get the things that are in those inner circles in mental health services.
Oh, I see. Okay, I get it.
So not suggesting that we do assessments in schools.
Yeah. Yes.
Sure.
So my name is Nabila. I want to ask you about why we shouldn't do this screening in schools, because I don't know, in my opinion, it will help the school to know which students that is more vulnerable to potentially traumatic situations.
Yep.
So yeah.
Yep. No, it's a good question, and I think there is a debate about this. There is debate as to how we conduct trauma-informed care in every setting. We are still trying to work it out. So there's still research going on. So currently we don't suggest we do this. The reality is, in many schools, the schools they often know the kids for whom this is happening to. Often it's happening currently to children in schools. So schools often know that already, and they have ways to deal with that. And they have ways to support those children in an ongoing way. So I think the idea of, so if you, in any setting, if you are going to screen, you need to have the resources to deal with what comes out. And so having a system where you screen and then you deal with what a child says is if we're going to screen, we have to have that put in place. And that maybe that's potentially a good thing, but there wouldn't be many schools that would have the resources to then deal with that, I don't think. And so this is the debate. This is always the debate with these issues, is how much do we probe, how much do we ask, versus it's very resource intensive to do that, versus how much do we watch kids, observe them, and if we see signs that something's going on, then we undertake a trauma-informed approach. So we think, oh, what's going on? This child's not interested in school anymore. What's happening? They seem sad, and let's go and have our trauma-informed care hat on and think, what might be happening at home? What might have happened on the way home from school? What might, so we're being a bit more strategic about our assessment.
May I ask more questions? It's still about how the community approach the people with traumatic history. It's still in the same topic. I want to ask more. Should we, the community, help people with traumatic history to avoid potentially trauma evoking situations, or should we help them to to be resilient with it and make peace with it? Because this is like a huge question to me. But you know, that we can't control everything, but everything can evoke trauma. We don't know which one that can evoke trauma to them. So yeah, I want to ask that.
Oh, that's a fantastic question. I think certainly in the countries I've lived in, New Zealand and Australia and the UK, those countries had a collective had and still do have a kind of collective not talking about trauma, like pushing it away. Not like they don't want to talk about abuse. They don't want to talk that people don't talk about their trauma. And that leads to PTSD. So we know that one of the ways that PTSD develops is if we avoid thinking about it or talking about it. That's the theory about how PTSD develops. So in the aftermath of trauma, we should be not pushing away the thoughts and feelings about the trauma. And I actually think that as a society, I think we're getting better as a society if we just talk about it more, if we talk about it and process it. So if something, happens, we go to our friend and and as friends, we listen. We're available to listen, and we don't shy away from hearing the details, because it's the details that people feel like they need to talk about. So everyone recovers from trauma in a different way. Everyone recovers from the acute effects of trauma in different ways. So some people want to talk about it a lot. Other people want to think about it, but they don't want to talk about it. And the research shows us that we should be letting people use their natural coping strategies to recover. So if they feel like talking about it, we should be listening. If they don't, we should be doing lots of social support, making them food and making sure that that we can see if they can have some time off work, or taking them to work, or just all those showing we care. So I think we should be better at listening to people when they need to be heard, and supporting people when they just want to get on with things. And collectively, we need to not be pushing these things, under the carpet. We need to be being the number of children who have these very, very traumatic experiences. That's not something that we talk about much in society. We're better at it. I think we're getting better at it. We need to improve.
Sorry, I still have more questions. So, because we kind of afraid of re-traumatizing others. So what I see from the student movement around here, like we kind of afraid to re-traumatize our friends that probably has rape history, or probably has sexual violence, or suicidal ideations history, or something like that. And we want to talk more about it. And when we talk, we use trigger warning. But there are people that argue that trigger warning is not enough, and then after that, okay, we listen to them that okay, trigger warning is not enough, and then we like we adjust the content, like we talk in social media, so we adjust the content to be as soft as possible.
Yeah.
But there are people argue too, like, why you make it like, why do you kind of spoil us to not talk about it? We just avoid these things. Like, so I want to ask you, like, to what extent we should avoid this issue, or we should talk about this issue, and is there any difference between like subtle cues or like an obvious cues toward this potentially trauma evoking situation?
Yeah, another great question. So this is not my area of expertise. There will be people that are doing research on exactly what you're describing, and that's not me. But based on my knowledge of how trauma the effects of trauma work, so I'm using that to answer your question. I would say that what we should be doing is I think trigger warnings are a good idea, but then we don't not say it. We give the warning and we say it, because if we're starting to step back from that content, we're avoiding. And avoiding, the society avoiding is not helpful, and we've done it for years and it's not helpful. I think stepping into it, talking about these things, and then providing support for the people for whom it is distressing is the way to go, which is why we do trigger warnings, so we can give people a bit of notice that it's coming, and then potentially providing support afterwards. I know that many of your lecturers have told you that if any of you need support after this talk, then that's available to you. So that's what we should be doing, not stepping back, stepping forward with support.
Okay, so one thing that I got is big conclusion that I got is, so avoiding it is not helpful.
Avoidance is not helpful. That is absolutely, we know that about PTSD. That pushing into it with support, pushing into the memories, stepping into life, not stepping away from life is helpful for trauma and the effects of trauma.
Okay, thank you so much.
Okay, thank you, Sarah. I have two questions regarding the implementation of trauma-informed. What should the best we do for if our client is already psychosis? In what level we can do that? Because sometimes the symptom of hallucination and everything is so dominant, we cannot move them to the past.
Yeah.
So what is the best? And the second one is for preventive. Like you mentioned before, it's happened in youth. So if we know that maybe some person have a traumatic event, how can we help them not to be a psychotic?
Mm-hmm.
Yep. What we should do first? Like what do you call? What is your name? Nabila said.
Mm-hmm.
How can we help them to prevent that he or she will be a psychotic in the future?
Yeah.
Okay, that's my question. Thank you.
Great question. So, in terms of psychosis, the TRIP model, we would usually be doing it when young people were recovering. So, in their very early recovery. So they may still have hallucinations and delusions, but they are ready to be doing some thinking and processing about them. So these are not, we wouldn't be doing it with people that were acutely psychotic, who were, say, still in an inpatient unit. Having said that, sometimes we find that young people who are not responsive to medication, who we can't use our usual containing medication and inpatient and supportive, social support, those things aren't helping them to recover. Sometimes we'll do a really thorough formulation and think that maybe trauma and PTSD symptoms are part of what's stopping them from recovering from their psychotic disorder. So it may be that it's an acute, there's acute PTSD happening as well as psychosis. We have sometimes tried to do trauma-focused treatments with those young people. So they're not so psychotic that they can't go back to the past and do some reliving. And we have had some, so it's done very carefully. It's a team-based decision to implement the trauma-focused treatment, and we set it up so we have a lot of safety mechanisms in place, and we have had mixed responses to that. Sometimes it has been helpful, at other times it hasn't resolved the psychotic symptoms. So that's your first, and then the second one is prevention. Also a really important questions. So one of the things that I think many of the traumas that we see in early psychosis services are interpersonal. They are traumas that have happened within families, and they sometimes happen because families are very stressed and distressed. And sometimes it's possible, we don't know this, but it's possible that children who are at genetically higher risk for psychosis may be more complex to parent, potentially. We don't know that, but that's a theory. So sometimes what's going on is we need to be trying to help. So in terms of prevention, we should be trying to prevent right at the beginning, pre-trauma. So this is very hard because it's all about public policy, it's about services, but we should be trying to support families to be less stressed, less distressed, more able to parent consistently, more able to have interventions to help for kids who have behavioural difficulties, so that parents have good strategies for how to deal with that and don't lose their tempers. So that's the very early prevention. Then in terms of so prevention of psychosis, post-trauma, that's a space that we haven't done much thinking about. Certainly we know that that supporting communities where there is community-based trauma is extremely important for children. So children can develop the long-term effects of community-based natural disasters, those kinds of traumas. They can continue to show effects long after their parents potentially recover. So certainly noticing children in when that's happening is very important, and providing trauma treatments for children so before they develop psychosis is I think very important.
For prevention, so this method can involve also the parents and significant others, not only the person itself.
Yes, yes, yes. We will bring families in as much as we possibly can. Yes.
So we're back to the online participants because we have several questions here. Valencia, I jumped to the last question, actually, two last questions. Valencia said, thank you, Professor Bendall, for the presentation. She asked about if the client with psychotic symptoms is currently still living in a traumatic environment and experiencing heavy stress every day, what are the things we will be able to do as a mental health professional to help the client managing the stress?
Yep, very good question. I think, Valencia, that the first thing is the fact that you know that happens is really important. So that's the first thing, is that taking a trauma-informed approach, we need to know the details of the context in which the young person is living. So what are the current stressors? Is the trauma still happening, or has the trauma changed, but there are still perpetrators in the young person's life? And this is where we are often hamstrung. We try very hard to support the young people to access services that might mean that they can move, or that they can change jobs. Or so I think focusing on and supporting, I think as a psychologist, it's absolutely our job to be working on those things as well as the psychological, if they are the things that are stopping the young person from getting better. So knowing those things, and then trying to support the young person to make changes if possible is essential.
So the first thing first is identifying the situation of the clients, and then decide what should we do with that.
What can we do? What can't we change? What can we change? Let's work on the things we can change.
Okay.
And then that can sometimes trigger other changes, better, more broader changes. So very important.
Okay. Okay. So we also have a question from, it's a long one, from Ibu Sekar Hanafi. So she is a clinical psychologist and she's running therapy of client with abundance trauma of civil war that made my client to hunt to be killed in certain period of my client's life. Just for giving the context, my client is an adult, not a young people as the recent presentation given, and has different cultural background from me. Related to such discussion in my case, I was wondering about considering on cultural safety. In my case, my client doesn't have any issues during psychotherapy session. The sessions flows comfortably, but my client always reports about the insecurities that appears in some nightmares. My client mentioned that it is forbidden to share about personal story to the stranger out of the family members in this context, including me as professional. So the question is, the phenomenon needs to consider as part of experience or hallucination or any other kind of concept, and how would be this cultural belief interfere the therapeutic process? I think this is the client is the old one, the older people.
Yeah, so I think what's being asked is it's a good question. Tell me if you think this is if you think I'm on the right track, that the being forbidden to share about the personal story, that may be cultural or it may be a hallucination. And I'm thinking that it's hard for the therapist to know which it is. That's the sense I get from the question. And what I would say, what I do, because this is not uncommon, that we quite often don't know whether a hallucination or a delusion is real or not. Sometimes they can be real. I would consult. I would see if you could find someone that you know who is of the same cultural heritage as the client, and consult on whether this situation sounds like it makes sense culturally or is a hallucination. If there's anyone in the family, that's always really good to, if you can connect up with, it may not be possible considering what you're describing here, but if there's, or friends, if there are friends of this client who might be willing to come in for a session,
yes,
or care, if there are other care workers who come from the same cultural heritage, come in and just unpack it. So unpack this. Is this really? Could this be a hallucination? Could this be a delusion that you are thinking that you can't share this? But or it could be really important in terms of your culture. Let's just have a think about that and see if we can work out which of those it is. That would be my suggestion.
Yeah, so invite the peers, actually, our clients' peers.
Yes, family, peers, with psychosis, pulling in the supporters of the person with psychosis is always extremely good to get us to kind of get a reality check, a sense check on how the person with psychosis is kind of conceptualizing their life.
Yeah, so Ibu Sekar raised her hand. You can unmute yourself, actually, and talk.
Yep. Am I audible, Mbak Hanum?
Yes.
Yeah. Thank you,
hear
Professor
you.
Bendall. This is kind of challenging case that I've faced recently. To my examination, I saw this is not hallucination, since when we were in a session that's going very consistent logics, and there is no weird or any kind of hallucination ideas regarding to my client. But I was wondering about the cultural belief that would be interfere the therapeutic process, since it just happened in the dreams report, which is not happened in the real sessions in the psychotherapy. Could you please probably give me an advice what I should do to probably prevent or going through what can be done to strengthen the process of coping with this kind of trauma rather than going deeply into the assessment that probably make it the trauma reappears. I hope I'm clear enough. Thank you.
I'm sorry. So this is so the main problem is your client is difficult for your client to share their personal story.
No, not at all. In the reality, it goes smoothly. But the problem is with the nightmares.
I see. Okay.
So the client's having severe nightmares.
Yeah, so the clients have severe nightmares.
And so does the client have PTSD? Do you know if do they meet criteria for PTSD?
I guess so, because my client is a civil war victim since 6 years old. Now the age is 37 and still have that kinds of memories disturbed every day.
If I would suggest that you do an assessment for PTSD and check to see if this person actually meets criteria. It sounds like they probably do, meets criteria for current PTSD. If they do, then it may be that a formal exposure-based treatment for PTSD like EMDR or narrative exposure therapy or prolonged exposure, that is the evidence tells us that is the most effective thing to deal with nightmares. And that, in my experience, they are very difficult to shift unless you do that quite structured treatment for PTSD. It's a bit odd. It's actually, I just find it amazing that it works so well, because the nightmares can be about something completely different than the trauma experiences.
Yes.
If you do that formal exposure treatment, then that's definitely, in my experience, has been the thing that has been most effective for nightmares.
Okay. So could I just deny the nightmares and just walking through the sessions, or could you give me any kind of advice regarding to this?
Can you repeat? Sorry, I just didn't quite catch the question. Could you repeat that, please?
So I get the message is, should I just deny and go forward to the session and ignore the nightmares, or should I have a special consideration to the nightmares?
I would be talking to the client about the fact that so if you assess for PTSD and you tell the client you're doing that and you tell them about the symptoms of PTSD, they will see that they have PTSD. So you're sharing the formulation with the client that they have PTSD if they do. And so nightmares is part of that diagnostic criteria, and they will see, you can show them. I often show my clients the DSM-5 diagnostic criteria, and then you can say to the client, the way that we try and make these nightmares reduce is to talk about your trauma. And I know it's I say to my clients, I know that sounds very strange, and it is, we're not talking about the nightmares, we're talking about the trauma, and that's very hard to do. But that is the evidence is very clear that the way to make the nightmares reduce or go away, and I have had experience of nightmares completely disappearing when you do a trauma-focused treatment. Okay. So it's really raising the client's motivation. It's not denying or ignoring the nightmares. It's saying the way to make these go away is to do this treatment. And the client kind of has to trust you on it.
Thank you very much, Professor Bendall.
I hope it answers your question. Okay, we can continue to the next question. We still have 3 more questions, Professor. So this is from Ibu Fitria. Is there any specific timeline that is commonly used to conduct trauma-informed approach? Is there general consensus on the number of sessions needed to be done to have an effective result?
Yeah, that's a very good question. So it very much depends on the service that we're implementing the TRIP approach in. So in Australia, our early psychosis services have young people have a 2-year episode of care. So they stay in the service for a full 2 years. So we can do the TRIP intervention over a long period of time. And we do it, we have a case management, a care coordination model in Australia where psychologists do the, they not only do the psychological work, but they also do the housing support and social services. And so they do social work. They do social work roles as well. So what we usually do is we do a little bit of TRIP. We integrate it into all the case management activities. So we're not necessarily doing a full TRIP therapy session of 50 minutes, say. Often because young people don't want to talk about trauma for a whole 50 minutes. Their distress thermometer has gone up high enough that it's time to do other things. So it actually works quite well to do it for 10 or 15 minutes in a session, and then come back and do a little bit the next week and a little bit the next week. So that's one way of doing it. Having said all that, I've never seen this. I've never seen a service that's managed to do this. But an ideal service would be doing the TRIP, would be implementing the TRIP trauma-informed care approach, and then having a specific trauma-focused treatment, adjunctive therapeutic process for those young people with PTSD, so that if they need it, if they have PTSD, having gone through the TRIP intervention, some of which reduce their PTSD symptoms if they just do the TRIP trauma-informed care process.
Okay, we move to the next question because we have a little time. So this is from Jessica Patricia. May I inquire, given the latest evidence on the relationship between childhood trauma and the development of psychotic disorder, what foundational research method or psychological theories should a first-year psychology student prioritize to effectively understand and contribute to the future studies in this area?
Oh, that's a good question too. What should, well, there are a lot of different ways of doing research in this space. And I've used a lot of different research methodologies in the time I've been doing this work. And the one that I've come back to and I do more and more of is qualitative research. And I feel like I've learned more from the results I've had from my qualitative research than I've got from other research I've done. And I think that's not the case in all areas of mental health, but I think it's the case in trauma and psychosis because we know so little about it. As I showed in those slides, we don't understand the relationship between dissociation, hallucinations and delusion, post-traumatic intrusions. We don't know what questions to be asking in order to really understand those relationships yet. And if we don't know what research questions to be asking, I think the way to go is qualitative research, where we use an inductive approach. We go from the ground up. We ask, what we usually do is ask young people about their experiences in a lot of detail, and then we analyze those transcripts. And that starts to give us clues about the relationship between all of those phenomena. And then later, we will be able to do quantitative research where we try and understand how we can start to put numbers and percentages on how much those, how important those processes are in the whole group. So at the moment, qualitative research, I would say.
So it depends on the aims of your research then.
It really does, yes, yeah.
Okay, and the last question here is from Ibu Pratiwi. So, hi, Prof. Sarah, I'm Tika. Oh, her name is Tika. I'm Tika from Semarang, and I'm newly graduated from clinical psychologist program. And I want to ask about how to conduct the preventive treatment of the first episode psychosis to be delivered to trauma young people after screening, based on the mechanism how childhood trauma can develop to psychosis. In my understanding, from the presentation, the EMDR, prolonged exposure and trauma-informed approach intervention is only delivered to patient with full first episode of psychosis with trauma personal history. Would you elaborate it, please?
So if you are seeing young people with trauma, then the job is to understand, it's to think back to that what is trauma and the 3 E's. So if you know that someone has experienced trauma, your job is to work out what the effects, as a psychologist, what the effects of the trauma are in the present. Like so you can actually do a lot of the TRIP intervention, even if a young person doesn't have psychosis. So you can do assess screening, and then you can do the narration, do the timeline, and do the distress thermometer, and that will give you an understanding of all the trauma exposure, and then the effects of that trauma, and that then you will have a formulation. And then you can make some decisions about what to do in terms of treatment. So if the young person has PTSD, if you do that process and you find that the young person has PTSD, then it would be fantastic to do a trauma-focused intervention with that young person. So trauma-focused EMDR, prolonged exposure, are highly effective for PTSD. And now we know they're also effective for PTSD in psychosis. So if you have a young person with PTSD, then by all means if you've been trained and you have good supervision, then undertake a trauma-focused treatment with that young person, and that will be good for them right now in the present, and also possibly will mean that they don't develop other difficulties in the future.
Okay, I hope it answered your question. So that's our last question, Professor, and I think we can end our discussion. But before that, please, all the participants here and online participant, please complete the survey by our committee, and the committee will send you the e-certificate through your registered email. So make sure that you put the right email on your registration form. Okay, so this is the end of our discussion. Thank you so much for your inspiring presentation. Big applause. And I hope you enjoy your day. So we can end our discussion today. Thank you so much.